Right. Very good afternoon for all of you. And on behalf of the Sri Lanka Association of Urological Surgeons, uh, we, the moderators and the South team, very warmly welcome you. And I'm very glad to hear that many of the surgical trainees are also with us. So urology is an essential part of the surgical curriculum. So it's great to have some participation and very warm welcome to all the South members, colleagues, and the trainees. So this is our second uh, sort of webinar on the advanced urological training. And today the topic is non-muscle invasive bladder cancer. And uh, conduct the today's webinar, I have my co-moderator, Dr. Balasingam Balagovi, and we have an eminent expert panel. Of course, Dr. Anuruddha Begunsekara needs no introduction. Senior consultant urologist from the Colombo South Teaching Hospital. And thank you very much for your participation, sir. And also we have Professor Mary Pereira, who will be joining us very soon. Again, needs no introduction. Senior consultant urological surgeon from the National Hospital. And we have a special expert uh, in the panel today, that is Dr. Krishanti Rajasurya. And thank you very much, Dr. Krishanti, for joining us today. And let me just give a brief introduction about her. She is a consultant oncologist from the teaching hospital Jaffna, and she graduated in 1997 from the Jaffna Medical School with very good uh, track record with second class honors and gold medals. And then she obtained the MD oncology in 2006 and obtained the FRA in ZCR in 2017. And she has got many medals and awards under her name. And she has done a many number of publications in both national and international journals. She has wide range of interest in mainly urological and non-urological oncological conditions. And most importantly, she has had a wide experience in working in many other countries in Australia and Singapore and Sri Lanka. And thank you very much, Dr. Rajasurya, for your contribution today and joining with us for this uromed program. So to conduct the rest of the proceedings, I would invite Dr. Balagovi to go ahead with the topics and the presenters today. Thank you.
Thank you, Dr. Nisandar. So today we have three major topics. The first one will be core topics that will be discussed by Dr. T. Samarasinghe. Then diagnosis and prognosis will be discussed by Dr. Nishantan. And the last part is a management of non-muscle invasive bladder cancer, which will be discussed by Dr. Munipriya. So the plan is each trainees will present the core topics for 20 minutes. Then between the presentation, there will be a discussion. So we will sometime we'll ask the experts on opinion, and trainees also can ask questions. So we will start with the first topic, the core topics. So I'm inviting Dr. Samarasinghe to present on core topics of on non-muscle invasive bladder cancer. Dr. Samarasinghe, over to you.
is Dr. Is it Dr. Tilina Samarasinghe?
Hello.
Hello. Yeah. Is Dr. Samarasinghe? Can you hear us?
Yes, sir.
Yeah. So if you can, yeah, on your camera and then move your presentation and start sharing, please. Thank you.
Just 1 second. Am I sharing my screen?
Yeah, you can go to the presentation mode so that you can have a full screen.
So you can see my screen, everything is clear, no?
Yeah, everything's clear, you're audible.
Good evening, everybody. Today's topic is non-muscle invasive bladder cancer. So I'm going to talk about the initial bit, the core topics. So what I'm going to talk about will be basically an introduction to hematuria, and I will briefly touch on the demographics, etiology, and then pathology, and some thing about molecular biology and presentation. Right. So first thing is, as we all know, this is basic stuff. So I might be a little bit boring, but first thing we have to identify is whether it's hematuria or it's pigmenturia. So all the red color urine is, as we know, is not always hematuria. And well, of course, there are few reasons for pigmenturia, but I will concentrate more on the hematuria part. It is mainly divided into visibility and timing. So visibility is when the patient presents with a symptom of hematuria, that is called visible, macroscopic, or gross hematuria according to different books. Or else, if we do a urine full report and identify microscopic or red cells in the urine which the patient has not seen, then of course it is considered microscopic hematuria. So the diagnostic and prognostic implications are slightly different, and the guidelines also have certain differences with regard to evaluation of these two, and specifically because gross hematuria has a higher risk of having a significant malignancy associated with it. I will come to that a little bit later. And then the timing of hematuria, of course, important, but it's not always so. But generally, it's considered that initial hematuria is from a urethral source, and a terminal hematuria is considered to be from prostate, bladder, neck, or trigone. And total hematuria will be usually when the urine or the blood is collected in the bladder and then it's released. So this is not absolute, but these are just important features in the history that will direct our further evaluation. And since this was included in the presentations, I just went into the nice recommendations of bladder cancer. This is for the referral to tertiary care pathway. So they have the guideline is for any patient more than 45 years with macroscopic hematuria. It's for urological evaluation. So I think my colleague will talk about what are the evaluations that has to be done with these patients. So, but the NICE guidelines is a little different from most of the other guidelines, where the non-visible hematuria or microscopic hematuria, they are evaluating only if age 60 and over have unexplained non-visible hematuria with dysuria or raised WBC count on blood tests. So that's a little bit different. Next slide, I will show the other guidelines comparison. And then after urinary tract infection also, they are saying persist. So first after UTI, you treat the UTI, and then still the macroscopic hematuria persists only, they are referring to evaluation within 2 weeks. Right. So moving on to the other guidelines, a slightly little bit more, the American guidelines and the Canadian guidelines are more or less similar, and they are a little bit more aggressive with regard to the evaluation, where they will evaluate microscopic, as you can see, these microscopic hematuria, if that is 3 or more red cells for high power field in any adult more than 35 years of age, with the routine things. So it will include a cystoscopy, ultrasound scan, and a CT urogram to assess the upper tracts. And most of the other guidelines are also somewhat similar with little few differences. And as you can see, they have included, this is I have taken from the Campbell. The NICE guideline is the kind of exception. And there's an obstetric guideline saying females of reproductive age can be avoided if they don't have any other risk factors. But apart from that, most of the other guidelines are more or less similar. So the causes of hematuria, this is of course a very busy slide, just to show a diagrammatic representation. Going into the glomerular causes, which we need the help of our colleagues, nephrology colleagues for further evaluation. The commonest causes are the IgA nephropathy. As you can see, this is from one study, which is done some time ago, but again, in Campbell also this is mentioned. So these are the causes of glomerular causes. So commonly what we see are these IgA nephropathies and the glomerular nephritis, post-streptococcal and all. So this is a kind of a pathway to see what is the most likely cause of this glomerular hematuria. Of course, what is important to us is probably this more on this slide, just to identify whether it is a medical or a glomerular hematuria or hematuria originating beyond, or a surgical hematuria. So we are in the clinical evaluation. If you are looking for respiratory tract infections, family history of any hematuria such as Alport syndrome. Don't know how frequent that is in Sri Lankan context, but it's somewhat frequent in other countries. Rashes for different reasons, as I mentioned before, and also new onset hypertension or edema suggestive of nephritic syndrome. And in the evaluation, serum creatinine and blood urea elevation, hypoalbuminemia, again, nephritic or nephrotic syndromes. And in the urine analysis, if we can see dysmorphic red cells or red cell or WBC CAS with significant amounts of albuminuria, those are the features that would suggest that we might be looking at a non-surgical cause of this hematuria. Saying this, most of the guidelines say once we refer for nephrological evaluation, if they don't find a cause, or if the hematuria is persisting, there's always an indication to evaluate for surgical causes as well. So the more interesting causes for us are the surgical causes. Well, there are a whole list of these. So neoplasms starting from the kidney up and from the upper tracts, bladder, and then the outflow. Anywhere in this tract can cause hematuria. Infections, calculi, benign prostatic hyperplasia. One reason that because it's so common, there's a significant amount of, although it is not common for BPH to cause hematuria, because BPH is common, we see a lot of patients with this. And then anatomical abnormalities. So there are a lot of things here in this slide. I'm sure you can't read all of this, but just to summarize. So going into our main topic about bladder cancer, we go into the demographics worldwide. It is considered to be very common, especially in males, seventh most common cancer in males, but when added to the female altogether, it becomes the 10th commonest cancer. And its rates have varied in different countries due to different reasons. And again, most of the people present with diseases confined to the mucosa or non-muscle invasive bladder cancer. This figure of 75% is an overall figure given, but it again varies. I think in Sri Lankan studies, up to 50% of muscle invasive bladder cancer have been seen in some of these studies. And yeah, since this has a very high longer survival, the prevalence is obviously going to be high. This is again UK figures. As you can see, the trends from 1983 coming up to 2015, the trends seem to be coming down in UK. And the age of diagnosis, of course, again, it is it peaks to at about 75 to 80 years. And going into the Sri Lankan context, well, we don't have a lot of data. There are a few retrospective studies. The two prominent studies that I came across done at National Hospital by late Dr. Gunawardena, and they have found a slightly higher male to female ratio, and also the incidence increase in incidences noted as opposed to the UK figures at that time. This is in 2000, reported in 2019. And females, the study was on females, and they had 50% higher muscle invasive bladder tumors in that study. Going into our National Cancer Registry, that this was 2015 data, that is the most recent data that is available. So again, I don't think this represents the true extent of bladder cancers in Sri Lanka as any other cancers. There are a lot of underreporting here. But in males, you can see this is bladder is in the top 10 cancers, 9th overall, and also incidence rates, age standardized incidence is rising according to the figures, but I don't know whether this is due to increase in reporting. And this is also age specific incidence rates again shows a rise, which plateaus up at about 70s. Going into the etiology very briefly, there are a lot of factors that have been tested and implicated, but the age-old most well-known factor is smoking, which is seen in about 30 to 40% of all urothelial cancers, and it is shown to increase the risk of death and recurrence. And it is also shown that stopping smoking is will reduce the risk. And there is a difference of patients who have stopped for 5 years and 15 years as well in some studies. And the causality is considered to be the aromatic amines in the tobacco smoke, which will be excreted through the kidneys, will be exposed in the bladder. So the second important risk factor is exposure to aromatic amines, polycyclic aromatic hydrocarbons. So these are in different industries, including dye, rubber, and painters. And even in recent times, with the especially in other countries with occupational hazard awareness, I think this has come down, and diesel fumes have been implicated to have a higher contribution in these countries. Again, Sri Lankan figures are not available. Genetic, there are a few gene mutations that were found. We will come to that a little bit later. Hereditary, there is no definite familial syndromes as such, but HNPCC or the familial colorectal, non-polypoid colorectal carcinoma syndrome with MSH2 mutations is considered to have a high risk of urothelial tumors. And first degree relatives also have a higher risk of developing urothelial bladder cancers, but family screening is not recommended in any other guidelines or pathways. BMI, there are some studies to say there is obesity has some contributory factors for higher grade and progression. Other medical conditions, again, implicated with poor prognosis, maybe due to difficulties in treatment as well, and chronic bladder irritation, especially for squamous cell carcinomas, is considered. Briefly going into the pathology, the histological types can be divided into benign ones, which we don't find commonly, whether it's due to missing it or maybe the probably the it is not as common as malignant lesions. Epithelial metaplasia, of course, it's just a focal area of transformed epithelium from the urothelium either to squamous or glandular epithelium. Papillomas and inverted papillomas. One important implication is this inverted papilloma is considered it's a benign lesion, but sometimes when you do cross-sectional imaging, you might see a large tumor. But when we do the cystoscopies, the urothelium looks absolutely normal. And they may also be associated with hematuria, including gross hematuria. But apart from symptomatic treatment, no further treatment is recommended for these papillomas. Nephrogenic adenoma, again due to chronic irritation, and it resembles a macroscopic papillary growth macroscopically. So it usually ends up being resected, but no further evaluation or follow-up is necessary. Interesting about this leukoplakia, in most other epithelia, leukoplakia is considered a pre-malignant lesion, and in some areas it is considered to be similar to a early malignant carcinoma in situ and has to be dealt with aggressively. But in the bladder, it is not. It has not shown to be a pre-malignant lesion, and it is not advised to aggressively treat leukoplakia. And then this cystitis cystica, which we see sometimes, it's a kind of a chronic associated with chronic inflammation or obstruction, and it's a proliferation of the Van Brunt nest. And management is suggested to manage the cause, which is either the infection, inflammation, or the obstruction, and to regularly follow up. But significant transformation into any malignancy is not documented. Then this precursor lesions, or according to the 2014 WHO classification. So there's a little bit of an overlap between this classification, where this, because you can see the malignant lesions, including the carcinoma in situ, is included here, but it's actually going into malignant lesion. These non-malignant ones, reactive atypia and atypia of unknown significance, and then the pre-malignant urothelial dysplasia are also considered precursor lesions of malignancy. And going into the malignancies, the commonest is urothelial bladder carcinoma, which used to be called transitional cell CA. And then the variants, which are seen in about 80% of these urothelial tumors. There is a micropapillary, sarcomatoid, plasmacytoid, or nested, or divergent differentiation. So that means there is primarily urothelial bladder CA with a squamous or a glandular component. This is not the squamous bladder carcinoma. So these have different implications. My next slide, I'll explain that. And then we see these non-urothelial bladder carcinomas as well, which is less than 10%. Small cell, squamous cell, and adeno. Again, squamous cell usually associated with chronic bladder irritation, and adenocarcinomas either from the urachal remnant or due to metaplasia, dysplasia from the native bladder epithelium. Variants, just briefly going into the implications, most of these variants have a poorer prognosis than pure high-grade cancers, and again, lymphovascular invasion also in these pathological specimens, again, poorer prognosis. And as I mentioned, there's 80% of the urothelial cancers will have some mixed differentiation. And this altered, now, as you can see, these are altered growth patterns, and this is a divergent differentiation. So altered growth patterns have a poorer prognosis, especially because neoadjuvant treatment, when we come to the treatment, the indications and will be discussed about neoadjuvant treatment, but efficacy of neoadjuvant treatment is for these altered, it's not for altered growth patterns, but for adenocarcinomas, SCCs, there might be some effect. Going into the grading, as we all know, bladder carcinoma is actually grade dependent rather than stage dependent, unlike in many other cancers. And grading was initially described in 1977 and then changed in 2004 and 2016, more or less the same classification. So initially it was grade 1, 2, 3, and then it changed to papillary urothelial neoplasm, low grade and high grade. So as you can see, the site of change is different. So there is a little bit of factors included in previously implicated grade 2, included in the high grade. So this is shown to be prognostically distinct, although this is all this in the new classification, all this is high grade. This area shown by the circle is thought to be prognostically more like the low grade or the grade 2. So they have used, now it's recommended for a 40-year system in the guidelines as well, as you can see. They say 40-year stronger prognostication and progression from the 40th. So they have divided this low grade, so grade 2, high grade and low grade, grade 2. And also this prognostic for progression, but not for recurrence. So by looking at the histology report of the initial TURB, we can get an idea about the progress, but not really the recurrence. I think again, this will risk stratification will be discussed further in the next discussion. And going into two important aspects, carcinoma in situ. It's non-invasive flat high-grade tumor. So it's a little different from other cancers where carcinoma in situ is considered to be the initial stage or the less virulent stage, but here this is a high-grade tumor. Always it's high-grade, and it has the genetic abnormalities are like an invasive or muscle-invasive tumors. So they have to be treated aggressively, and they're associated with worse prognosis rather than a PTA1 lesion. This is the other end of the spectrum, where the papillary urothelial neoplasm, again, this is if you can see in the previous one, it is lesser in the spectrum than the grade 1 or the low grade tumors. So they have a very good prognosis. So these are just few figures. A very wide spectrum is given, but just to see. So recurrence rates, grade progression, and stage progression all are progressing from the papillary neoplasms to the low grade to the high grade. They are progressively increasing, and grade progression also from papillary neoplasms, of course, is about 10%. So is documented, and stage progression, that is, if the tumor is initially confined to the epithelium, for it to go to the muscle or beyond, is very low for papillary. Whereas if it's a low grade or a high grade, it's much higher. And as resultantly, the survival also decreases. So going again, staging, important aspect is clinical staging will include the TURB specimen, and the pathological staging truly will be only from the either radical or partial.
Tulina, could I disturb you for a minute?
Yes, sure, sir.
Yeah. With regarding the grading, so currently when we use grading, we use most of the time 1970 WHO grading rather than the new 2004-2016 grading. Do you have any idea what is the implications of these two staging system, and why the older system is more widely used among the urologists?
I think it is because prognostically it is found there is some evidence, some studies to say that the older system is slightly superior than the newer system, and the other thing is as I mentioned in this slide, the grade 2 is again included into the high grade in the new one. So this circle is actually working like the lower grade.
Yeah, that's correct. That's exactly the right answer, because the older system with G123 has a better prognostic sort of ability. But what happens with the newer grading is when you divide them into low grade and high grade, many of the G2 is categorized as high grade in the current system. So there is a inter-pathologist variation in the reporting also. So that's why, as you said, now they are suggesting low grade G2 and high grade G2 as a 4-tier system. Yeah, go ahead with the stage. Thanks.
Yeah, going into the staging. So the most implication is, sorry. Yeah, so most important differentiation is whether it is T1 or beyond. So T1 is muscle invasive, and beyond that is T2 is muscle invasive, and T3. So from in the T1 also, substaging of the T1 is again shown to be of prognostic value. So the TA and the T1 is again has important implications, and so it is important in the TURB specimen to accurately look into that. Again, in the bladder epithelium, the T2 also is substaged into superficial muscle and deep muscle, which has a lesser prognostic implications rather than the T1 sub classification. Again, nodes and METs are included in the 2017 UICC classification, but generally, if there is nodal metastasis, I think radical treatment is usually or radical cystectomy rather, is usually not advised, but I think this will be further discussed. Going a little bit into molecular biology, it might be a little bit tiring, but I just highlight the traditional pathways. There are two traditionally described pathways. First, one is the urothelial proliferation differentiating into a low-grade invasive papillary tumors. And this is the FGFR3 mutation. That is the usually low-grade pathway. And then the second pathway was a dysplasia transforming into a carcinoma in situ and going into high. So these are the two pathways that were actually still widely described pathways. But newer studies, including the genomic sequencing done in 2014, have complicated the matters a lot more, and not complicated, but it's difficult to for us to remember. But they have found out very accurately about the drivers of this bladder cancer development and progression. And these genes, as you can see, are accurately described, and they have found similarities with the, as we all know, the breast cancer is extensively studied, and they have found they have differentiated into the luminal and basal, and these two enriched pathways, and they have found striking similarities in the bladder cancer as well. So these are different classification systems. The TCGA 1, 2, 3, 4 system is the cancer genome atlas differentiation. So the important implications are, since these complex genetics are identified, as you can see, the treatment pathways, actionable targets are also described. So if we can do the genomic sequencing in these tumors, in our dissected specimens, we can identify these genes. We can identify who will benefit from immune checkpoint inhibitors, who will benefit from growth factor inhibitors, and then who will benefit from FGFR3 inhibitors. Again, this has a very significant therapeutic implications. And also we can prognosticate more accurately regarding the tumor behavior, and also maybe reduce the incidence or reduce or increase our frequency of follow-up of these patients, rather than now currently what we use is low risk, intermediate risk, and high risk, and then our follow-up is tailored according to that. So we may be able to give a more precision treatment with regard to management, as well as follow-up with the development of these new genetic modules. So I will conclude my presentation on this, and then I think further discussion will be from the other two speakers.
Thank you, Trina. This was a concise and with a lot of information, very useful. So I want to ask, you said the non-visible hematuria. So what kind of imaging usually you do in a non-visible hematuria after the initial workup in a routine in your clinic setup?
If generally with non-visible hematuria, I think as I showed you, the guidelines are different, but generally we will see whether there is any other cause, especially an infection or any other thing. If there is no significant other cause, I think we will err towards safe side, or that is towards the American side. So there is, I think we will go ahead with the ultrasound scan, confirm cytology, and then ultrasound scan. And then also, I think we will go ahead with the flexible cystoscopy and CT IVU as well, depending on the patient's other risk factors as well. It's a more than 35 years, smoker, other any other risk factors are present, I think non-visible will be considered more or less like a visible material.
So thank you, Telina. Neville sir, so the AUA guidelines and the Canadian guidelines say to do a CT urogram for a non-visible hematuria, but the BAUS says to do an ultrasound scan. We also do an ultrasound scan. So what is your opinion, sir?
Yeah, I think the age plays a big role. You know, when age is over 40 or 45, and I think as a screening procedure or a first round investigation, we will always do ultrasound scan, and then if we find something, then we'll proceed on those lines. In the younger people, again, I think straight away going for a CTI view. In my practice, I don't do it, but others, if ultrasound and flexible cystoscopy doesn't give any answer, and there is persistent microscopic hematuria, say in 2 or more samples with cytology negative, I will go for a CT urogram because I think there is a possibility of missing upper tract urethral carcinoma otherwise. And if that doesn't give an answer, I will continue with bilateral ureteroscopy even. Because I think halfway through, we should not stop investigating them if we don't get an answer. Persistent microscopic hematuria. So, I think I take the age as a sort of important factor. Say over the age of 40 or 45, I will be always, comfortable if the first round investigations doesn't give any proper answer for microhematuria. I will go for CT urogram. I wonder whether there is other opinions about it.
Sir, so the incidence of carcinoma in situ, what do you think? In Sri Lanka, is it common like other countries, or we have a lesser incidence? Sir?
My experience, I think even primary, secondary, or concomitant CIS, the 3 groups, all 3 groups are relatively rare. Maybe we are not looking for them because we are not doing routine biopsies. I mean, even when we are doing a TURBT, unless we made a positive effort, conscious effort to take biopsies, random biopsies from the rest of the mucosa, we will never know the proper incidence. I don't know whether it's Anuruddha's or others practice to do routine bladder biopsies with the TURBT or even with a flexible cystoscopy for if you see a suspicious area, we will biopsy. So my experience is that the carcinoma in situ, even primary or secondary or any kind of carcinoma in situ incidence is much lower.
Sir, what is your opinion, sir?
The problem is, I think, whether we don't know whether we are not looking for it or not. What will you say, Anuruddha?
Yeah, I agree with you, sir. Primary carcinoma in situ is almost unheard in Sri Lanka. Other 2 we don't look for. So anyway, there is not much of a clinical significance in those 2. Therefore, it's not that important. But the primary is almost unheard. I agree.
Yeah, that's very true. Yeah.
Dr. Krishanti, what is your experience with carcinoma in situ of bladder?
We rarely see CIS. And
right.
also a question to Prof. Neville. So, sir, for this non-visible hematuria, will your approach change based on the gender?
Yes, the thing is that investigation guideline, I think, doesn't based on gender actually. I mean, in my practice and guidelines, I think gender variation or gender preference is never being mentioned. I don't know in anybody's practice, you do anything more or anything less depending on gender. Is that the question? Am I answering the question?
Yeah. So.
Yeah, that's right. Because of this menstrual blood getting mixed with urine, that's why I asked you that question.
The thing is that you are careful when you are collecting the urine sample. I think to make sure that the patient has not is not menstruating, and it is being very clearly said in guidelines. You have to see microhematuria, non-menstrual periods, and 2O in 2 or more specimens. So to be very precise about it. With a single specimen of hematuria, and though we start investigating them, I think it's always, if there's a doubt about menstrual blood or contamination, you can go ahead with a couple of, but in older women, again, the menstruation is actually not a problem. So again, the age comes into the scene. So 45, 50, I think even with the first sample having significant hematuria, I would go ahead first round.
I think Kelina
Is there any other
mentioned,
evidence to sort of show that?
Kelina mentioned that the female patient with the bladder cancer usually have aggressive disease. I think the reason is we investigate them later because we attribute their hematuria for a UTI. So that is the maybe the one reason why they come with the late stages. But actually, I think we should investigate both sectors together.
Tirina,
But then we should always look for other associated features of cystitis and infection, like pyuria and presence of pyuria and signs of inflammation. So yeah, I think I agree with you that. But I think we always advise, even to the GPs, that don't ever attribute hematuria unless there is significant pyuria associated with it and there's a positive culture. Don't attribute it to infection, and to refer the patient to us for further investigations.
So in other countries, they have this urine dipstick test, and then most of the time the infections are ruled out with the dipstick, and then then and there they will spot check the sample for the hematuria. So
but
we don't have that.
Yeah,
we don't have that, so that may be a little bit of a issue when you think of infection and sort of differentiate it with the frank with non-visible hematuria.
Yes, but dipstick, as you know, Shanta, will have a bit of pitfall because for dipstick to become positive in dipstick samples, there should be more than 10 red cells per high power field spun urine, but significant hematuria is defined as more than 3 cells per high power field. So that between 3 and 10, there is a window of missing significant hematuria when you do the dipstick. So dipstick, still the cystoscopy and investigation for bladder cancer will continue even if the dipstick is negative. But dipstick will be negative if there is no more than 10 cells per high power field. So this pitfall is there with the dipstick. But I agree with you. Dipstick will give some idea about the presence of infection from the same strip. But we have to know about these. We have to sort of be aware of this window of 3 cells and 10 cells.
Yes.
So regarding the pre-malignant condition, sir, what about the keratinized squamous metaplasia? What do you think? Is it a pre-malignant condition, or how we have to?
Yeah, I think we see this on and off in women. I think the white plaques on the urothelium. Whether it is actually pre-malignant, I'm not quite sure. But if the report comes as such, I will keep under surveillance, because any kind of metaplasia is, I think, a sign of some sort of a mucosal instability, epithelial instability. So I will keep under observation if we are taking a biopsy and if we have if it has been reported as that such.
So pathology says that there are 2 types of squamous metaplasia. One is keratinized. What we usually see is a white plaque is a non-keratinized squamous metaplasia. So all the reproductive age group female will have that in trigone. So that, of course, no need of any follow-up. But if it is a keratinized, it will look a gray color. That, of course, is they say is a pre-malignant condition for a squamous cancer. What about the cystitis glandularis? Is it a pre-malignant condition for adenocarcinoma?
Actually speaking, I have seen a number of those cystitis glandularis. They're like little cystic areas and blobs and blebs in cystoscopies, but I think we have stopped biopsying them even because my feeling is that this is not pre-malignant. unless there is guidelines, you know, the new guidelines says that to biopsy them. Anybody else has different?
I also agree
experience?
with that, sir.
Yeah.
Cystitis has never become a malignancy in our hands also. But about microscopic hematuria, I have a small question from Tilina. Now, my approach is little more conservative for microscopic hematuria. I do only ultrasound scan. I would like to know what is the rate of malignancy. That is what you are worried now. Your investigating protocol was not different from visible and non-visible. But what is the positive malignancies in microscopic hematuria where ultrasound has not found?
So I don't exactly know when the ultrasound has missed what is positivity, but the described rate is microscopic hematuria about 5%. By I think 2.5 to 5% of the time can yield a malignancy, whereas visible hematuria I think it's about 20%. And this microscopic hematuria also they have found if the count is more than 25 per high power field, that has about 10 to 15%, 10 to 12%, I think. So somewhat higher rate, significantly higher rate of detecting the malignancy. Again, these are from individual studies. I'm not sure whether these are meta-analysis. This is mainly found in the Campbell. So that is the figures that are given. I think most of the studies give this 5% figure, but how when we add that to the ultrasound also, how many of these we don't know. Again, I think the problem with ultrasound is if we are to miss this small either the upper tract lesions, the upper tract urothelial tumors, or the small bladder tumors. No, sir. I think larger bladder tumors or renal malignancies, of course, will be renal. Of course, will have a similar sensitivity for the CTI view and ultrasound, more or less. I'm not sure of the figures, but I think that is like that.
Yeah, may I speak? The ultrasound, the biggest problem is, can you if you can hear me?
Yes, sir.
There is no standardization of doing ultrasound for bladder tumors at all, because you are supposed to look at the bladder wall when it is fully stretched bladder wall. Otherwise, you can miss less than 5 millimeter, or flat lesions can be completely missed. So because of that, ultrasound is always taught as a unreliable investigation for detecting bladder tumors, especially superficial, non-muscle invasive, flat or early tumors, papillomas, and tumors which protrudes into the lumen even will be clearly seen only if the bladder is stretched. So unless we put these guidelines to radiologists and say that this is, we are looking for a bladder tumor, look at it when bladder is full, really full, and it has to be a sort of experienced ultrasonographologist also. I think we can't be 100% dependent on ultrasound finding for bladder tumors.
Then last question before moving to the next topic. Neville sir, so if you get a patient with visible hematuria, you did all the investigation, flexible cystoscopy, CT urogram, all normal, but still patient is bleeding. What to do, sir?
Yeah, and the find that lateral ureteroscopy. That fatty and various, vascular anomalies and pseudoaneurysms, AV malformations, and things like that. But I think you should not miss sort of drop bilateral ureteroscopy with same things like narrowband imaging and things like that. Or if that semi-rigid one fails, we have to go ahead with a flexible ureteroscopy and try to peep into all the as many calyces as possible. So between all these things, that will become the final measure. That also doesn't give an answer. When you go for angiography, that also doesn't give rise to give any answer. Then you imagine that you sort of by exclusion of malignancy, you have to go for other benign diseases, and very rare benign diseases like nutcracker syndrome or some kind of Jogger's hematuria or some glomerulonephritis, some sort of a medical hematuria problem. So once we have excluded it at that level, a surgical problem.
Thank you, sir. So I think it's a time to move to the next topic. I'm inviting Dr. Nishant to discuss about diagnosis and prognosis of non-muscle invasive bladder cancer. Nishant?
Nishantan, you have to unmute. And the audience, I would please invite to sort of direct your questions in the chat so that the experts can look into and we can sort of direct into experts and we can get the expert opinion on your questions. Thanks.
I'm Dr. Nishant then. Am I audible to you?
Yes, you are.
Okay.
And put the presentation in the presentation mode.
Can you see the slides?
Yeah, we can see your slides. Please go ahead.
Yeah. Now I am going to discuss about diagnosis and prognosis of non-muscle invasive bladder carcinoma. So this slide will give the overview of diagnosis when we have the clinical features of hematuria or irritative lower urinary tract symptoms. So in that case, we will investigate the patient, or otherwise the patient might be coming with the ultrasound KUV where he might be found to have a bladder swelling. So then with this investigation and the clinical features, we might go for a flexible cystoscopy or rigid cystoscopy where we can find the bladder lesion. Then we will go for a QRBT where we will have the histological diagnosis where we can differentiate whether it's a muscle invasive or non-muscle invasive disease. So according to the histology, we might have to go for a look for a synchronous lesions. For that, we might have to do the further investigation, CT IVU and IVU. This is the brief outline. So clinical features, of course, hematuria is the most common finding in non-muscle invasive bladder carcinoma. And visible hematuria is common with the higher stage compared to the non-visible hematuria. And carcinoma in situ is mainly give rise to symptoms of irritative voiding symptoms. Examination findings are in non-muscle invasive carcinoma. They don't have significant examination finding, but where the muscle invasive carcinoma, they can have pelvic mass, which can be filled with bimanual palpation. We will move into investigations. So the gold standard investigation is up to now the white light cystoscopy, which has a sensitivity of 98% and a specificity of 94%. But its invasiveness and which need the expertise. Because of that, there are still looking for some other investigations, non-invasive investigations. So we are considering the urine cytology and biomarkers we are considering. So we will be discussing about the cytology. Cytology, we take the voided urine or bladder washings for cells. Sensitivity, of course, it has high specificity, more than 90% in experienced hand, but sensitivity varies according to the grade of the tumor. So high grade tumors will give around 84%, low grade tumor around 16%, but carcinoma in situ, the sensitivity varies 28 to 80%, 100%. Because of that, positive cytology they can have urothelial carcinoma anywhere in the upper tract, urinary tract, but negative results will not exclude the malignancy. And also the results can be affected by low cellular yield and UTI, stones, and intravesical installation of the drugs, and also according to the experience. So it's about collecting the sample, and Paris system is normally used to give the report that to categorize the cytology report. So this is the way where we have to categorize the cytology findings, and we should know whether the cytology is useful in our clinical practice. So according to the newer guidelines, surveillance purpose, particularly as an adjunct to cystoscopy, where the patient is having high-grade tumor. So in the follow-up, we can use the cystoscopy plus cytology, because we don't want to miss the patient. We want to identify the patient early. So because of that, in that aspect, we can use the cytology. Positive results of cytology in patients with a negative cystoscopy. Of course, we have to look for other upper tract lesions. So if that also negative, then we have to watch the patient carefully, because they have, even though cystoscopy finding is negative, they are more prone to get the recurrence and also progression. And urinary molecular markers. I mentioned about the cystoscopy, and I mentioned about the cytology. So the problem with the cytology is it has high specificity, but low sensitivity. So because of the low sensitivity, there are further investigations we are looking into. So one is urinary molecular markers. Numerous urinary tests have been established, but up to now, none of the guidelines or routine practices have accepted for the diagnosis or follow-up of the non-muscle invasive tumors. Sensitivity is.
You said if there is a positive cytology,
Yes.
with negative flexible cystoscopy, you do a upper tract workup.
Yes.
So what do you do?
In that case, the patient is found as the cystoscopy is enormous. We can go for a CT IVU if it is available. The patient is. Otherwise, we can go for a X-ray IVU. If those are also negative, then we have to consider the follow-up. Then if that also fails, then we have to consider the invasive invasive technique to assess the upper tracts.
Some guidelines said put a ureteric catheter and wash the right ureter and left ureter separately and collect the urine. I don't know. So do we do that, or?
Yeah, that is only if you hit a blank wall with all the investigations. But I think there is something in between you should mention, not only cystoscopy, random biopsies. I think if cytology is positive and visible cystoscopy is negative, you do random biopsies, 6 to 12 pieces from all over the place, because sometimes the carcinoma inside to certain areas are not visible at all. Sometimes you see it as a red patch, but sometimes you don't see anything. So random biopsies followed by upper tract investigations. And if you still, now bilaterally you have to do that. But if there is nothing to do a brush biopsy or a punch biopsy in both upper tracts, to get specific cytology from each pelvic health system, this selective catheterization and barbotage or washing, taking renal pelvic washings have been described. But in practice, I have hardly ever considered that. Only visible lesions.
During random biopsy, do we have to take a biopsy from prostatic urethra as well?
Yes, if it is, we are looking for a primary carcinoma in situ, prostate urethra is a must, because that is one area you can get, because it's all the urothelium. So biopsies including prostatic urethra and the trigone.
So they have mentioned to take a resectional biopsy from the prostatic urethra rather than the cold cup biopsy, because sometimes they said there may be a carcinoma in situ in the prostatic duct tubes. I don't know. We have never seen.
Yeah. Yeah, I think doing a prostatic resection, I mean, you have to take a couple of loops, I think, from the bladder neck area. I think in a patient, I think you have to get special consent for all the bladder neck defects you are going to get. I think that's theoretically true, but I think prostatic ductal urothelial cancer is kind of a rarity without, seeing a visible tumor there. So I, of course, have never considered that so far.
So do you believe cytology, urine cytology? Do you have in the era of all these investigations and imaging, do you believe the urine cytology?
Yeah, I think it all depends on the pathologist. Not all pathologists are cytologists. If you see the cytology books, they have 2,000 pages in each book. So I think to get a reported by a trained cytopathologist with the addition of immunocytohistochemistry for the cytological analysis, I think just saying that they are suspicious of cytology, and I have followed up number of patients, about 3 or 4 females for years, for these positive cytology, and without finding a primary site, and ultimately hit a blank wall, finding nothing. So I think the reliability of cytology all depends on whether we have a dedicated urological cytopathologist, or at least a cytopathologist. Not all the pathologists could report cytology. And I think we should always request for immunocytohistochemistry.
As a recent paper have said, sir, they have analyzed 3,000 urine cytology. And they have said in only one patient, cytology was helpful to diagnose a bladder cancer, because in other patients, already the bladder cancer was diagnosed with the other investigations.
I think that I totally agree with it, because my practice doesn't depend much on the cytology unless I really hit a blank wall and then desperate to find a place somewhere to cancer cells.
Nishant said, yeah, it's helpful in surveillance. Yeah, sorry to disturb, Nishant, you can continue from there.
Thank you, sir. So sensitivity about the urinary molecular markers, sensitivity is usually higher, and first is it has a low specificity compared to cytology. It has high specificity but low sensitivity. Here, of course, it has good sensitivity but low specificity. So benign conditions and previous BCG installations can influence the results. So the clinical use of the urinary molecular markers depend on the patient selection and the clinical context. So where we are going to use it for the screening or primary detection, follow-up, it depends on the patient selection. So clinician must adjust the practice according to that. So wide range of performance markers. So they are saying that even though the specificity, in the America, there are 5 tests approved by the FDA. According to their studies, they show good sensitivity and specificity, but still the other guidelines are not recommending for the clinical usage. Only in selected cases only they recommend to use, because of the low reproducibility, and laboratory methods are also complicated. So our future development should be the very high negative predictive value. We should develop a urine molecular marker which should have a very high negative predictive value. If it is negative, then it should be, there should not be any tumor. So that will be the better marker which will benefit for the clinical practice. So there are some promising urinary markers are under assessment, but still not in the market. So currently available molecular markers are, these are the available markers which are recommended by FDA of America. And in American AUA guidelines, they say the biomarkers can be used for the assessment of intravesical BCG treatment. So that for that purpose, they are suggesting, still it's an expert opinion. And so still in America, as I mentioned, that 5 markers already approved, but not in clinical practice. Mainly they suggest assessing the intravesical BCG treatment effect, and if they have an intermediate cytology, so in that context they can use the urine molecular markers to further clarify the finding. So these are the markers with sensitivity and specificity. So according to this AUA guideline, they say around 70% or more or less most of the markers are having same specificity and sensitivity. Usefulness in clinical practice. The positive results in the cytology and the molecular markers, where the negative cystoscopy and upper tract work, I think in previous also we discussed, they having the more recurrence and the progression. AUA guideline furtherly use these molecular markers, assess the intravesical BCG treatment response, and also intermediate cytology. So cytology and urine molecular markers together, how we can use in clinical practice. So screening purpose, they say in the screening where we can use the molecular markers and the cytology, the patient who are having high risk of bladder cancer. So we can use it as a screening purpose, where they have done, the researchers have proved that application of hematuria dipstick followed by the molecular markers positive has been reported screening in the high risk population. And for the primary detection, first diagnosis, where the patient is having hematuria and other features, clinical features suggestive of bladder tumor, but cytology, cystoscopy is done, but still they can miss the findings. So in that case, as an adjunct, we can use the this cytology and the urine molecular markers, mainly in the carcinoma in situ. And surveillance, in the clinical context of surveillance, mainly the researchers suggested that high-grade non-muscle invasive bladder carcinomas, where we can use cystoscopy plus cytology, because we don't want to miss the high-grade tumor recurrence and the progression. Because of that, we can use both. And also the cytology has high sensitivity in high-grade tumors. So because of that, we can use for the high-grade tumor only for the surveillance purpose. For the low-grade tumors, there is a limitation. Cytology and the current urinary markers, they are low sensitivity for low-grade tumors. So because of that, they are not used in low-grade tumor follow-up. Evidence is level 1B. So these are the studies related to the urinary markers. There are multi-center studies and randomized control studies. These are the results. 1B evident for the follow-up. And ultimately, the no urinary marker can replace the cystoscopy during the follow-up, or it can't reduce the frequency of the cystoscopy. So cystoscopy is the must So any markers at the clinical context can't replace the cytology and reduce the frequency of the cytology, cystoscopy. And there was a one prospective randomized control study. It found that knowledge about positive test results before doing the cystoscopy improve the quality of the cystoscopy. If you know that the patient is found to have a urinary molecular marker is positive, before doing the cystoscopy, it improved the quality of the cystoscopy. There's a randomized control study. And the screening for the bladder carcinoma is not recommended because bladder cancer has the low incidence, around 9.5 to 2.4, and also it has short lead time. Also, when after doing the diagnosis, there will be a there will be a fast progression. But so because of that, even if we diagnose it, there won't be any significant change, benefit by diagnosing the patient early. So early, because the progression will be more faster. So because of that short lead time, the routine screening of the bladder carcinoma is not recommended. This is the study. And cystoscopy, as I mentioned, the gold standard sensitivity is 98%, specificity is 94%. And the practical aspects of cystoscopy, we have to document the finding according to this diagram. And new methods in tumor visualizations to improve the sensitivity of the cystoscopy. Normally, the cystoscopy uses white light. White light can lead to it can miss some visible lesions. So there are newer technologies, photodynamics, fluorescence study, and narrowband imaging study techniques are there to improve the cancer detection level. So there are these two techniques are there, and further new techniques are there. These uses ultralight for the intravesical installation, 5LA and HAL. Confirm that guided biopsy and the resections are more sensitive in compared to the conventional method. They say that identifying the malignant tumors, mainly in the carcinoma in situ, it has good clinical practice. And a review article. In a systematic review, there the photodynamics study had higher sensitivity than the white light in the patient level as well as in the histology level. So 92% compared to 71% in the white light cystoscopy, and biopsy level 93% compared to white light, where it is 65%. But problem is, even though the sensitivity is more, but the specificity is the problem. And there was another study regarding the photodynamic imaging, where the study said that already positive cytology patient undergoing TURBT, there won't any significant changes by using the photodynamic imaging. Randomized control study. So as I mentioned, that it has low specificity than the white light endoscopy. That is the problem with the this imaging. And false positive results can be seen if the patient is having UTI or recent TURBT or BCG installation. So during that, if we are using that, then we have to be careful during that period. And ultimately, there are systematic review of 14 randomized controlled trials where the decreased risk of bladder carcinoma recurrence in the short and long term, but there was no difference in the progression and mortality rate by using the photodynamic imaging. And narrowband imaging, where we can see the high vascular mucosa more enhanced with a narrowband imaging. Improve cancer detection are there, but still the inflammatory lesion also can give rise to a hypervascular lesions. So negative, again false positive results are there. So according to that, still the randomized control trials are done, but narrowband imaging, overall the results are negative for narrowband imaging.
Chandan, you have 7 more minutes.
And about the additional technologies, there we can use the spices, and these imaging technologies are under evaluation, not in clinical practice. And investigations, of course, imaging, ultrasound for the hematuria workup, we can visualize the bladder masses or hydronephrosis. And CT urogram, of course, we can see the urothelial carcinoma as in filling defects, and also can identify the secondary effect, hydronephrosis. Also the pelvic lymph nodes and other pelvic organs also can be assessed, but we can't assess the depth of the muscle invasion. So to assess the muscle invasion, the TURBT specimen is the better one. If CT is not available, we can use the IVU. And also, if we are the already diagnosed patient with the bladder carcinoma, whether we have to use the CT IVU to assess the synchronous lesion is a question. So the reason is only 2% of the chance is there to have when we have the bladder carcinoma to find the upper tract lesions. And also in the other way around, if the upper tract lesion is there, then we are having 30% risk to have bladder carcinoma. And also 7.5% of upper tract lesion is there if the tumor is found in the trigone region. So according to the current guidelines, we have to use for non-muscle invasive bladder carcinoma only when we find that tumor is involved in the trigone area and multiple lesions, high risk tumor. We have to use CT IVU to detect the synchronous upper tract lesions in non-muscle invasive bladder carcinoma. And MRI, of course, it can give good information, but still depth of tumor and invasion can be assessed, but still the clinical indications are not established. And about the progression rate and the recurrence rate, to assess the after doing the TURBT, we are going to assess the patient risk for progression and the recurrence. According to that only we are going to plan the further treatment. So to assess the progression and the recurrence, there are scoring models are there. So for the management decision, so there are EORTC group scale is there, which has 2 scores, recurrence score and the progression score. And another scoring system is mainly Spanish trial, driven from the Spanish trial, CUETO score. We can. So this is the CUETO score, where it uses the number of tumor and the size of the tumor diameter, and prior recurrence. According to this, it gives 2 values, recurrence and the progression values. And other EOT scale, it give recurrence and also progression score. So it gives the risk in 1 year time how much, the 5 year time how much. So according to that, we have to adjust our adjuvant management, adjuvant treatment. And newer scoring model, they have in EAU 2021, they have a newer scoring model where they have mainly for the disease progression, they have added the previous WHO 1973 and WHO 2004 classification system both together. Because of that, after doing this study, they have included it. So they are not including the patients who had adjuvant intravesical treatment because it reduced the progression of the disease. Because of that, they are not taking that patient into this scoring model, but they consider the TURBT patient, TURBT plus intravesical chemotherapy patient into this scoring model. So these are the factors included in the scoring system. So it's the only available model where the WHO classification 2004 and the 73 models are included. The risk of tumor progression, but not the recurrence. We can use the other model to calculate the risk of disease recurrence. So these are the risk stratification system where we, after doing the TURBT, we categorize the non-muscle invasive tumors into low risk, intermediate risk. Yes.
So you have mentioned about 6 factors in the EORTC.
Yes.
So what are the 2 main factors that decide the recurrence? So there are grade and stage and number of tumor, size of the tumor, and number of recurrence, and so and associated CIS. Out of this, what are the 2 main things have decide the recurrence of tumor?
Grade of the tumor.
If you see, the number of tumors and the prior recurrence are the major factors. Those decide the recurrence. And there are 2 major factors decide the progression, actually 3. One is grade and the stage and associated CIS. Those are the 3 factors decide the progression, and the number of tumors and previous recurrence rate. Those are the 2 factors decide the recurrence. You can see this chart, they give more scores for those factors. Yeah, okay.
So this is the latest one where we can see that previous one had a fundlum also in that system under low risk. Because of that, I think Dr. Nishandalina Patranagi discussed about that previous grading system and the current grading system. So latest one, they have used that the previous table again, where they didn't consider the pendulum one in the low risk tumors. They have straight away used the previous model. And subgroup of highest risk, where as Dr. Balagopi mentioned, the CIS, presence of CIS and the prostatic urethra involvement and limbovascular involvement, those further make it as a highest risk tumor where they have high risk of going for a recurrence and the progression. So they consider it as highest risk, where in that situation we can consider even upfront cystectomy management. Comparing the risk stratification system related to the EAU guideline and AUA guideline. AUA guideline, there are small difference. Low risk category, they have considered that TA less than 3 centimeter and papillary urothelial neoplasm. So they have different way that any BCG failure, those kind of things are also involved in the high risk classification. And BAUS give more or less the EAU guideline classification, where they are not having the highest risk category, but other than that, the low risk and intermediate risk category is there. And about the TURBT, the TURBT technique can be resection can be done as a piecemeal technique or en bloc technique. There are still the studies going. The adequacy of the TURBT depend on the dextrosal muscle present in the specimen. So absence of the dextrosal muscle is related results in residual tumor and local recurrence. And we can use the bipolar or monopolar. So I can say I can discuss with the monopolar bipolar differences, and laser we can use the laser fulguration also for small low grade lesions. Diathermization also can be done. So first we have to do examination under anesthesia and bimanual palpation. Then we have to do the, I think these are the practical aspects. After the resection of the tumor, we have to resect the base of the tumor and the edges, and we have to document the diagram. So indication for the prosthetic urethral biopsy, I think we have already discussed. If we if the patient is found to have a bladder neck tumors or suspected to confirm carcinoma in situ or positive cytology without evidence of tumor in the bladder and visible abnormalities in the prosthetic urethra. So these are the indication for prosthetic urethral biopsy. And indication for random biopsies from the normal looking mucosa when the cytology is positive, history of high grade and the high grade tumors, and tumors with non-papillary appearance. These are the indication to have random biopsies. Second, TURBT. It increases the recurrence-free recurrent-free survival, and also improve the outcomes after the BCG treatment. And also it gives prognostic information. So level of evidence is grade 3. Second TURBT is recommended in selected patients. Mainly the time period is after between the 2 to 6 weeks after initial TURBT. Should include the resection in the primary site. So indication for the second TURBT, if we have done the incomplete initial resection, then we have to do, and no muscle in the first specimen, then we have to go for it. But except in TA and low grade tumors and carcinoma in situ, we can avoid second if the muscle is not included, then we can avoid it. And T1 tumors, level 1B evidence that we have to go for a second TURBT. Where the TA and T1 high grade tumor demonstrated 51% of the time they can have persistent tumors. Understaging also 8% risk is there to understage the T1 tumors. And monopolar and the bipolar resection, still the trials are there, but RCTs, randomized controlled trials are there. Whether the monopolar or bipolar resection are good, but still the results are controversial. But compare the bipolar bladder perforation due to the obturator nerve jerk is theoretically considered as less, but evidence are controversial. Surgical strategies for the tumor resection, where we can use the piecemeal resection, which is actually against the oncological principles, but ideal will be the en bloc dissection. But studies shows that if we are able to, even if we do the piecemeal resection, if we are able to completely do the resection, that will also give a good response level of evidence is 2B, and en bloc resection we can use the monopolar bipolar laser. Mainly we can use for the exophytic tumors, not for it is not possible to do in other lesions. So it gives high quality of resected specimen where the assessment of histology will be easier for the histologist. So presence of so level of evidence is 1B if we are able to do, but the technique is where we doing the en bloc resection depend on the experience of the surgeon and of the location of the tumor. So that depends.
Thank you, Nishanthan. It was detailed and with the evidence. Thank you very much. There are a few questions from our colleagues. Dr. Suranga is asking if a female is coming with the recurrent UTI, do we have to do a flexible cystoscopy?
Yes, it is not a culture-proven infection and culture-proven cystitis, and there is more predominant hematuria rather than pyuria, I will certainly go for a cystoscopy and biopsy of suspicious lesions or even random biopsies, because this rare occurrence of malignant cystitis presents just like that with irritative symptoms which can mimic cystitis. But that is a rare occasion where the symptoms are culture negative, irritative symptoms mimicking cystitis.
Also, recurrent culture positive UTI?
Culture positive UTI, of course, you have to exclude other predisposing factors for UTI now first of all. And cystoscopy will not provide that much information, but unfortunately, there's a rare situation where there can be blood tumors, but especially when it's associated with hematuria, which can undergo necrosis and secondary infection on the necrotic material, which can just mimic a UTI or a cystitis. So I think there's no answer to the cystitis. I think go ahead with the cystoscopy.
Another, sir, if a patient come with the bladder tumor which was detected in the ultrasound scan, suppose a 3 centimeter papillary growth, do we still have to do the flexible cystoscopy, or can we proceed with the TURBT?
Not sure, but probably possible, no? To do a TURBT.
EAU guidelines, of course.
Yeah, Nishanthan might know.
Yeah, EAU guidelines says if the patient is ultrasound, in the ultrasound he is found to have a lesion, then we can straight away go for a TURBT, rigid cystoscope.
Okay.
We can see the images of radiologist ultrasound scans picture, and I think we are happy with the appearance, then I think we can proceed with the TURBT.
Yeah, there's a slight problem I see with straight away going for resection just after ultrasonically detected SOL, because if it is a muscle invasive cancer or doubtful muscle invasive cancer, then of course you get the TURBT effect on the CT, post-operative CT. Because once you have resected it, you know there's extravasation and there's a lot of inflammation going on. So if you just thereafter, if you go and do a CT, that can be reported as muscle invasive, or there may be that's called a TURBT effect. So unless it's a really pedunculated, nice looking little T1 or TA tumor, I would rather get the CT before I go for resection. If it is a broad-based tumor they have reported, go for the CT first and get the information and then go for TURBT. The guidelines, I mean, we can exclude the guidelines. We've done that several occasions. If the pedunculated mass, you can go ahead and do the TURBT solely depending on ultrasound.
Suppose you do it, yeah, Another sir.
No, the question was actually whether to do a flexible cystoscopy, no, not the CT.
Yeah. Yes, sir. Yeah.
So I agree.
That is, of course, it's superfluous,
Yeah.
because if you see a good
That was the
radiologist has
question.
reported a bladder mass,
Yeah.
you go ahead with the procedure rather than
Yes.
just looking at it
Yeah.
again
Yeah.
and then.
Yes.
So, sir, you do a
So we do
TURBT.
it maybe straight for CT rather than an in between flexible cystoscopy.
Yeah, you do a good TURBT with the muscles, and you have seen the perivesical fat. But the pathologist says no muscle available in the histology. So why sometimes we get that kind of reports, sir? What is your opinion?
Yeah, if you're asking me, that is the sampling error. It's a sampling problem is there, because unless you send an en-bloc sample of the tumor, it's not possible all the time, because large tumors you can't send en-bloc sample. With this TURBT, they, especially large TURBTs, they check the specimen in, they separate the specimen into areas, and then they take random samples and check it. So they can always miss the muscle containing part. So what we have to do is just ask for resampling. You tell the situation and then ask them to resample and cut more blocks, if you are pretty sure that you have taken muscle. But if failing that, of course, you have to wait for the scar to form, because we have already seen the fat outside. So give a little time, say 3 weeks, 3 to 6 weeks, go in and then resect the scar and take some random biopsies and see. Because best thing is to ask for resampling, because next sample they might say that muscle is found, but never accept bladder tumor report without muscle included.
So when you go for a resection, for the biopsy from the deep layers, do you really recommend to go for a resectional biopsy, or what about getting the cold biopsy from the biopsy faucet, where you can go for a rather good depth, and especially the lateral wall, you do sometimes with the effect of the spinal. Do you think that makes any difference, the cold biopsies from the deep biopsy faucet, or from the resectional biopsies?
Yeah, I wonder what Anuruddha's practice is, but generally, if you are doing cold biopsies, that has to be done on a freshly resected TURBT crater. And taking punch biopsies from a scarred or inflamed crater of a post-TURBT wound might not represent what we really expecting to find. So I think another resectional biopsy is recommended, but I'm not aware of any kind of comparative studies or anything between these two techniques.
Yeah, one of the things that I have found is when you do a resection, sometimes when you send some resectional samples, they get diatomy artifacts and all. So when you do a TURBT and from the fresh tumor bed, if you use biopsy faucets and take good chunks of deep biopsies, including the fat and all, most of the time the yield is good, and you can also ask them and send them as separately. So that's what I have seen. The other thing is there any difference between the bladder perforation rates in bipolar diatomy resection versus monopolar resection, or are we having some problems because now the current day bipolar systems, even though they are called bipolar, most are quasi-bipolar, the kind of pseudo bipolar. So have you seen any difference between the adductor jerk between these bipolar and monopolar systems?
Yeah, to be honest, I think I have done many more monopolar resections than compared to bipolar resections. The thing is that if you are anticipating some kind of operator reflex, then of course you ask the anesthetist to paralyze the patient and then go ahead with the resection. And if you think that you can't complete the TURBT and it's repeated operator jerks, you ask them to paralyze and do it. So if you are more selective in paralyzing the patient and doing it, I have not found any difference between bipolar and monopolar. Because even bipolar, as quite correctly you said, they are quasi-bipolars, except ACMI machine. All the others transmit current through the sheath, not the from loop to loop. So you get even with the bipolar, I have seen people getting operator chair. So I don't think there is
Yes,
any
yes.
difference between perforation rates.
The quality of the specimen, is there different? Regarding
Actually, there's hardly any difference because in the pathology report, the report regarding the diathermy effect, I have not seen any difference. But I'm not quite sure what the others think.
so sometimes
So I think even with the bipolar, you get this the loop is getting red hot, and I think the diathermy effect will be the same, and some sort of plasma effect is also going. So I think all the literature, when you look at the literature, the newer bipolar systems are two bipolar systems. So we'll have to wait for some time to see whether there is any the improvement between the sort of electrical conductivity in the nerve. But all the previous literature just compares the pseudo bipolar system.
I think time is running off, so we will move to the third presentation. Then we will come back and discuss all of the question. I think and invite Dr. Munipriya. He's going to discuss about the management of non-muscle invasive bladder cancer. Dr. Munipriya, over to you.
Thank you, Gopi. Good evening, everybody. I got the topic regarding the non-muscle invasive bladder cancer and management. Can you see the presentation?
Yeah,
Right.
we can see your presentation.
Yeah. Right. The objectives of this presentation is adjuvant treatment options. Those are intravesical chemotherapy, intravesical BCG immunotherapy, and combined therapy, and when to select the adjuvant therapy and evidence, especially the Sylvester meta-analysis. Further details of intravesical chemotherapy and then intravesical BCG and management of carcinoma in situ, follow-up after treatment, and what is the place for radical cystectomy in non-muscle invasive cancer. However, management is start from seeking smoking, I think, because smoking is increasing the risk of the tumor, increase the risk of tumor recurrence and the progression. So there are evidence to say there are few papers published. So because of that, we have to promote the patient to cease the smoking at least after finding the bladder cancer. Then, as my colleagues told, the endoscopic surgical management comes first. So TURBT, removal of all visible tumors, and the provide a specimen for histology to determine the stage and the grade of the tumor. So after that, we can decide redo TURBT, that is within 2 to 6 weeks time. Indication for redo TURBT, as initially mentioned, the high-grade disease and the no muscle included in the initial TURBT. And all suspicious lesions should be sampled, and random biopsies are not required in low-risk patients. And fluoroscopic cystoscopy with 5-amino levulinic acid derivatives improve the ability to visualize the inconscious tumor and the recurrence, reduce the recurrence rate after TURBT. So main topic, when I move to main topics, adjuvant treatment, the options is intravesical chemotherapy, and the intravesical BCG immunotherapy and combined therapy. Intravesical chemotherapy, immediate single instillation treatment is the mainstay, and additional instillation and the what are the things we can improve the efficacy of intravesical chemotherapy, I'll discuss in next. Should we consider the adjuvant therapy for non-muscle invasive cancer? Yes. Adjuvant therapy is needed considered all low and intermediate risk patients unless contraindicated. Main contraindications are the TURBT complicated with bladder perforation or extensive resection, which can lead to postoperative bleeding and the blood clots. No benefit has been found in patients with high-grade disease the given adjuvant treatment. Then what is mechanism of, when we come to the mechanism of action of intravesical chemotherapy, the tumor cells implants immediately after TURBT is responsible for early recurrence. Usually the, the floating tumors can be reimplant in the dome of the bladder. Usually the primary tumors will be on the trigone and the bilateral uh, uh, lobe areas, and during that time the tumor cells prior to implant and cover the implanted tumor cells with the extracellular matrix. We have to give the intravesical chemotherapy to kill those cells. That is the mechanism. So when we come to the evidence, especially the Sylvester meta-analysis, he has done a few series of studies, and in 2004, the first thing, decrease the risk of whether the intravesical chemotherapy for TURP, for TA, T1 and tumors, whether the risk is decreased. That is the study he wants to do. He has done meta-analysis using 7 randomized controlled trials. The number of patients included in 1,476, and median follow-up is around 3.4 years and maximum 14.2 years. And out of these cohorts, there are 267 out of 728 people selected for immediate single installation with epirubicin, mitomycin, or thiopeta, and pirarubicin, other agent, and other one is TURP alone, that number of 362. So out of this study, he come to the conclusion the giving intravesical single installation immediately will reduce the odd number of recurrence by 39%. And if it is a single tumor, tumor recurrence reduced to tumor recurrence will be 35.8%, and if it is a multiple tumors, still there is a tumor recurrence of 65%. Then the main study of the which we want to discuss is in Sylvester meta-analysis. That is published in 2015. According to the EUA, non-muscle invasive bladder cancer guidelines recommended single immediate installation of chemotherapy for all low and intermediate risk patients, but it is controversial. Because of that, he started the study, that is systematic review with individual patient data. So he has selected 13 randomized control trial as eligible publications during 1985 to 2011. So they have compared the immediate single instillation with epirubicin, mitomycin, tiotepa, and the uh, pirubicin and TURP alone. So the concluded results is immediate single instillation reduce the relative risk of recurrence by 35% and the 5-year recurrence rate by 14%, except in patient with prior recurrence rate more than one recurrence per year, or uh, European Organization for Research and uh, Treatment for Cancer recurrence score more than 5. Other thing is it increase the risk of death in patient with high risk cancer, and these are the studies he used, and these are the summary. And right, then when we come to the further details of the intravesical chemotherapy, single instillation postoperative intravesical chemotherapy with gemcitabine and mitomycin C, epirubicin, and pirubicin within 24 hours of TURBT for low and intermediate risk suspected or known cancer is beneficial. So evidence of gemcitabine uh, insulation compared with the saline irrigation shows significant reduce of the risk of recurrent over median of 4 years, and need to compare gemcitabine with other intravesical agent, but there is no studies uh, uh, at the moment. So avoid when suspected perforation and extensive resection. That is the recommendation, group B recommendation. Then no overall impact of single instillation of apocyquin, but it has shows if it is intravesical chemotherapy as a intravesical chemotherapy, if we use within 90 minutes, it has role for reducing the risk of tumor recurrence. So additional instillation, so depend on the progression, and low risk patient standard and complete treatment is the single instillation, but other groups we can consider the additional instillation to reduce the tumor recurrence and the progression. Single instillation only versus single instillation with repeat installations. So there is a one study that shows further chemotherapy installation after single installation improve the recurrence-free survival in intermediate risk patient. That is 2A. The level of evidence is 2A. This is the paper. So the comparing option for adjuvant therapy, the meta-analysis, there is a 11 randomized control trial, and 300 over 300 and 500 patients used, and showed high significant reduction of odds recurrence at 1 year of chemotherapy over the TURBT alone. So two meta-analyses demonstrated the BCG therapy may reduce the risk of tumor progression. It is a level 1A evidence, and BCG maintenance appears to be significant better improve uh, preventing the recurrence than the chemotherapy again. So this is the actually the chemotherapy compared with the BCG, which I discuss in future. So importance of single instillation of intravenous chemotherapy, single instillation plus further repeated instillation was compared with the latter repeated instillation only. So it is with the intermediate risk patients that single instillation might have impact on recurrence even when further adjuvant instillation were given. So significant uh, effect in intermediate and high risk group of patients receiving additional adjuvant mitomycin instillation, but it is still level 2A evidence. So according to this study, the value of intermediate intravesical instillation of mitomycin C in patient with non-muscle invasive bladder cancer, they were concluded an immediate single instillation after TURBT reduced the recurrence risk in non-muscle invasive patient independent of number of adjuvant instillation. So
Dr. Munipriya, you have 5 more minutes.
okay, thank you. Right. So this slide shows the summary of evidence of intravesical chemotherapy. So level 1A evidence shows the single instillation reduced the recurrence rate compared to the TURBT alone for low risk non-muscle invasive cancer patient and who are not prior low recurrence rate and the let's EORTC recurrence score less than 5. And side effects of intravesical chemotherapy, main commonest side effects is local irritation and chemical cystitis, cutaneous desquamation, and the decreased bladder capacity, and the calcified scar formation, and subsequent which added difficulties of subsequent cystectomy. The serious consequences rare, rarely death also reported, and then administration technique. So after resection, confirm absence of clinical perforation, place three-way catheter into the bladder and in the operative room, attach inflow port to the saline infusion bag and clamp inflow, administrate a chemotherapeutic agent through the catheter outflow port in the recovery room within 6 hours of operation, that is the ideal time, and clamp outflow uh, tube in with hemostat to allow retention. Open outflow tubing after 1 hour uh, and uh, allow gravity drainage for next 30 to 60 minutes. Remove Foley catheter and discard the biohazard container. This all the things should done with wearing the gloves as a precautions. So efficacy of intravesical chemotherapy, mitomycin C most effective adjuvant intravesical agent, but it should be give within ideally within 6 hours time, and the maintenance therapy does not reduce the risk. Single mitomycin and the epirubicin immediately after resection reduce the tumor recurrence, particularly initial presentation of solitary papillary low-grade tumor, that is level 1 evidence. And what are the ways we can use enhance the efficacy of intravesical chemotherapy? The one is the pH adjustment and the duration of insulation and drug concentration. There is a level 1B evidence for intravesical solution reduce the recurrence rate. So uh, and another example for level 1B evidence for concentrating the epirubicin can improve the reduce the tumor recurrence and time duration can adjust. Further enhancing techniques are device-assisted intravesical chemotherapy, which we can use the microwave-induced hypothermia, which is increase the intravesical heat, and it will affect increase the efficacy of chemotherapy. The other technique is a hypothermic intravesical chemotherapy and electromotive drug administration. So, according to the risk stratification, we can recommend the treatment accordingly. So, intermediate and high risk, most probably we are recommended rather than the intravesical chemotherapy, other treatment modalities. Low grade tumors, we can recommend the intravesical chemotherapy. Then intravesical BCG immunotherapy ideally have to infiltrate 2 to 4 weeks after initial tumor resection. It allows re-epithelialization, minimize the potential for intravasation of live bacterium, mycobacterium, and before that, we have to exclude the UTI, significant bleeding priority to the therapy, and to reduce the systemic uptake by bacteria. So, infection and the bleeding can increase the systemic upload. So, if the catheter trauma, we have to delay the BCG, intravesical BCG therapy at least for 1 week. Delay in asymptomatic bacteriuria is questionable still. Administration of intravenous BCG. The technique is BCG powdered vaccine is constituted with 50 ml of saline administered through the urethral catheter under the gravity. Ensure adequate retaining for at least 2 hours. Advice to patient limited dilution by restricting fluid, caffeine, and the diuretics. Clean the toilet with bleach after the voiding. So there are contraindications. So out of that, absolute contraindication for BCG therapy is immunocompromised patient, uh, and then intravasation of risk of intravasation due to gross or visible hematuria and traumatized catheterization. Those are absolute contraindication, and the systemic invasion of the bacteria risk is there too. Because of that, first 2 weeks after TURBT, we are not given the intravesical BCG therapy. Also, we are not given the total incontinent patient. Patient will not retain agent. That is why we are not practicing to give intravesical BCG for incontinence patient. So there are so many relative contraindications such as liver disease, personal history of tuberculosis, and poor overall performance status and the advanced age, urethral reflux, anti-tumor necrosis factor medication. So those are relative contraindications. So do BCG statin affects the efficacy? The efficacy of BCG strains for treatment of non-muscle invasive bladder cancer. The systematic review and network meta-analysis shows uh, BCG strain exhibit significant difference in efficacy compared to the against chemotherapy. No definitive conclusion regarding the strain's superiority. So side effects, local side effects, cystitis, hematuria, uh, granulomatous prostatitis, and epididymolysis. And systematic side effects are the arthralgia or arthritis, persistent high-grade fever, fever more than 38.5 centigrade for more than 48 hours, and BCG sepsis and allergic reaction. Those are the systemic side effects. So induction versus maintenance and scheduling of BCG. The optimal schedules for both induction and maintenance are not fully known. It can be different each patient. Induction as empirical 6-weekly schedule introduced by the Morales study, and for optimal efficacy, BCG must given in maintenance. That is level 1A evidence. Many different schedules ranging from total of 10 installation given in 18 weeks to 27 over 3 years. So that is the ideal way. Then EORTC meta-analysis was unable to determine which BCG maintenance schedule was most effective. The meta-analysis, another meta-analysis by Ball concluded that at least 1 year of maintenance BCG is required to obtain superiority of BCG over mitomycin therapy. There is a randomized control trial using more than 1,000 patients. EORTC has shown full dose 3 years BCG maintenance, 3 weekly instillation, 3, 6, 12, and 18, and 18, 24, and 30, and 6, 36 months. Then reduces recurrence rate compared to the 1 year in high but not in the intermediate risk patient, mainly the high risk patients. No differences in progression or overall survival. Another randomized control trial using 397 patients. High-risk tumors may maintain schedules with only one instillation 3 monthly for 3 years, may be suboptimal. That is level 1B evidence. So intravesical BCG failures, there are few categories, and BCG unresponsiveness, and late BCG relapsing, and the low-grade recurrence after BCG for primary. So these type of patients, the treatment options BCG unresponsiveness, the strong evidence for radical cystectomy, and even in late BCG relapsing, the strong evidence for radical cystectomy or repeat BCG course according to the individual situation. And low-grade recurrence after BCG for primary. So both treatment options are weak strengthening, that is repeat BCG or intravesical chemotherapy or radical cystectomy. The combined therapy, the combination of BCG and chemotherapy, there is a level 1B evidence for mitomycin and BCG combination. So it effectively reducing the recurrence but more toxic compared to BCG monotherapy. That is the problem with the combined therapy. So using similar BCG schedule, both groups, each BCG installation in combination group was proceed a day before by one mitomycin installation. That's so. Other combination is there is another randomized control trial using mitomycin with EMDA, that is uh,
Munipriya, you have 1 more minute.
right, okay. So I will go to management of CIS. So CIS is not cured by endoscopic procedure alone, but fortunately in our part of the world is it's less number POCIS. So concurrent CICs increase the risk of recurrence and progression in TA and T1, and CIS should be treated with intravesical BCG or radical cystectomy, but it is level 4 evidence. The tumor-specific survival rate after immediate radical cystectomy for CIS are excellent, but large proportion of patients might be overtreated. So that also in level 3 evidence. The retrospective cohort studies on CIS, the complete response rate of 48% was achieved in intravesical chemotherapy and 72 to 93 with BCG. That is good. So that is a level 2A evidence. So that is the one of the main option for CIS. Up to 50% complete responders might eventually show the recurrence with risk of invasion and extravesical recurrence. That is level 3 evidence. So there is a meta-analysis of clinical trial compared the intravesical BCG to chemotherapy has shown significant increased response rate after BCG and reduction of 59% in odds treatment failure with BCG. That is level 1A evidence. Then another meta-analysis, tumor progression uh, of subgroup of that group with CIS, BCG reduces the risk of progression by 35% as compared with the intravesical chemotherapy or different immunotherapies. So combination of BCG and mitomycin was not superior to BCG alone, and in summary, compared to the chemotherapy, BCG treatment of CIS increased the complete response rate, the overall percentage of patients who remain disease-free, reduced the risk of tumor progression as well. CIS in prosthetic urethra and upper urinary tract. So patient with the CIS high risk for extravesical involvement of urothelial lesions, that is in upper tract and the prosthetic urethra. So, and 63% of patients with CIS develop extravesical involvement initially or during follow-up. So extravesical involvement had worse survival than those with bladder CIS alone. So prostate CIS might be present only in the epithelial lining of the prostatic urethra or prostatic ducts, which were discussed initially, must be distinguished from tumor invasion into the prostatic stroma.
Munepriya,
Yeah.
there is a time constraints are there.
Okay.
So
Yeah.
could we just give a summary at the end of the last bit of topic, which is the radical
Yeah.
cystectomy for non-muscle invasion?
Yeah.
Can you put a summary slide?
Just, yeah. So, when to offer the radical cystectomy for non-muscle invasive bladder cancer? In patient with a TA low and intermediate risk, radical cystectomy should not perform until the bladder's sparing modalities such as stage TURBT intravesical therapy have failed. The consider offering the initial radical cystectomy for following cases, that is high risk patient fit for surgery with persistent high-grade T1A disease on repeated resection, or T1 tumors with associated CIS and variant histologies. Those are grade, the recommendation is grade C, and other category is high risk patient with persistent or recurrent disease within 1 year follow-up treatment with 2 induction cycles of BCG or BCG maintenance. So those are the recommendation for radical cystectomy for non-muscle invasive bladder cancer.
Right. Thank you, Munapriya.
Thank you.
So again, that was extensive topic. The bladder cancer, non-muscle invasive bladder cancer is quite an exhaustive topic, so we'll have to sort of stick to main discussion. So just a few questions to the expert panel. I would like to ask Dr. Krishanti about the BCG therapy. In our setting, do we consider the dose reduction approach to the BCG, or we give a fixed dose for everybody?
No, we give the standard dose. We give 80 milligram per installation, because there is evidence to say that the reduced dose is inferior to the standard dose. But in my experience, the tolerability is very poor. I'm yet to see a patient who completes 1 year of maintenance, because they get severe chemical cystitis and most of them stop halfway through.
So the next question is, if somebody comes with a severe cystitis feature, do you still consider dose reduction or give some other modality, or you consider some systemic therapy?
So when they have a cystitis, we always do a urine fluid report and a culture, but pus cells will be anyway there because it's an immune reaction. And also we try anti-inflammatory drugs and sometimes bladder muscle relaxant. And then if they don't settle and if there is an infection, we treat. But we don't straight away reduce dose.
In Sri Lanka, why we are not getting the MMC to the urologist post installation?
I do not know, but even I saw a question as to how you decide whether it's a low-grade tumor. So we always get a request from the urologist just to send the MMC to the theater. So actually, I have no experience. We only instruct the pharmacist to prepare and send. The urologist can do, but I have no objections.
And why there is a global shortage of BCG all the time?
Sorry, even I read about it, but I actually don't know the answer for that, Balagobi.
But in Sri Lanka, we have, is it available or?
Yeah, no, we have severe shortage on and off, short stocks appear. So they like usually we get interruptions in treatment.
And if you have a patient after BCG, end of 3 months, check cystoscopy, again positive tumor, what do you do?
So we actually then we request a urologist to re-resect, but and to check whether it is muscle invasive or not. So if it is muscle invasive, then we have to decide whether it's bladder preservation, concurrent chemoradiation, or cystectomy.
Do you give?
So that comes under that what he presented, the refractory BCG refractory disease.
Do you give one more induction? If the tumor is same stage?
No, we usually give 6.
At the end of the induction, at the end of the induction, we do cystoscopy after 6 weeks. The tumor is there, and we resect it. Same stage and grade. Do you give one more induction or?
To be honest, I haven't come across that situation in practice, Balagobi, but I think that patient falls under BCG refractory disease. So I don't think repeating BCG is useful in that patient.
Shanti, I also agree with you that I also have hardly seen any patient who have completed the BCG treatment. So why don't you start a small trial using only a smaller dose in Sri Lanka? Because our population have this BCG vaccine at birth, so they may be responding differently.
True, I agree, sir, but we don't have that many patients to run a trial unless it's a multi-center trial.
Because here in Colombo, it's
Yeah,
very
I
difficult
think,
to convince the oncologist to give intravesical BCG. I don't know, Neil Perraz's experience.
Yeah, I think in fact, my oncologist, of course, they wait for the patients to come to give intravesical BCG, either at Paharagam or in the private sector. So I have, for last 25 years, I have like Anuruddha. Anuruddha has been successful. He has been putting adriamycin long time ago in his ward. When I started doing that, the nurses were up in arms and they said that they are not going to get pregnant and there are various things. I said that our fertility rate in our unit is very high, so don't worry about it. But even that couldn't convince him. So they were totally against it. So some of my trainees, they even built up separate rooms and they tried various things, but they never agreed to have chemotherapy in the ward or in that case, even in the theater. So they have various misconceptions. So this immediate installation of MNC failed. And then BCG, of course, we didn't even try putting it in the unit. So everybody goes to the oncologist. And most of the time, I mean, I totally agree that they don't complete the course. I mean, halfway through, they get this severe reaction, and occasionally I see a BCGiosis. I'm yet to see a full miliary TB, ensuing with that. I don't know the Anuruddha has seen or others have seen, but they don't complete it, and they are halfway through this. So, may I ask a question from Krishanti? That
Sorry, sir, the connection is breaking up. I didn't get your question.
MMC or low-grade BCG for the high-grade treatment.
Sorry, sir, the line was breaking up. Can you please repeat the question?
No. The thing is that you have a sort of a preference to go for MMC for low-grade tumors and recommend BCG for high-grade tumors.
Yeah, MMC for low-grade tumors, sir, and BCG for intermediate and high risk. But the maintenance, the guidelines say for maintenance for intermediate 1 year maintenance and for high grade 3 years, but none of our patients even have completed this 1 year. So going for 3 years is, I don't think, ever possible.
Yeah, so in those patients, do you try MMC? Because
only if they recur, sir. But what I have observed is people who react badly, they don't recur that easily. So maybe the immunogenic reaction is very strong, and that's an advantage.
And the BCG failures and BCG failures, that recurrence after that. Do you try any other chemotherapeutic regimes like PCG, paclitaxel, gemcitabine combination?
For intravesical instillation or systemic chemotherapy?
Systemic.
No, systemic we don't unless it's metastatic. Because those schedules are also quite toxic. Unfortunately, the bladder chemotherapy schedules are very toxic. So they rarely qualify for chemotherapy.
What about radiotherapy for high-grade P1?
Yeah, that's a good question because there is a RTOG study going on for stage 1 bladder cancer, the trimodality treatment, but the results are not out yet.
Now, during the BCG, when you put a catheter, if you see some amount of blood in the catheter, do you give BCG or you postpone?
No, that's a contraindication because there is a risk of infection. So you have to at least allow the patient to rest for a week before you try it again.
And there's a question from Dr. Niroshan to Neville, sir. If you have tumor in the diverticulum, how do you manage, sir?
Yeah, I think that is a very tricky situation because initial TURBT can be complicated by perforation because there's no bladder wall to prevent it. And depending on the grade, I think you have to take it as a muscle invasive cancer, especially if it is high grade. If possible, you try to resect it with extreme caution because very easily you can perforate it to get the histology and to achieve certain degree of tissue diagnosis. And if it comes as intermediate or high grades, I think it's better for us to go ahead with a cystectomy or kind of definitive radio cystectomy rather than doing anything lesser. Because without the protective bladder musculature, and the follow-up will be difficult and management will be more difficult.
Yeah.
But if it's a low-grade cancer, I think you can follow the same guidelines.
There's a question from Dr. Niroshan again. If there's a tumor over the vesico-ureteric junction, after resection, do you put stent?
Yes, I tend to put the stent there once you have cut it. But actually, whether that's going to serve any purpose, I'm not quite sure, because those tumors, if those are invading the lower ureter, or it is a lower ureteric tumor invading the bladder, in both cases, some sort of a further treatment have to be done. So if it is a superficial or low-grade tumor, once you have resected, and if you think that you have burnt or you have done a lot of diathermy there, leaving a stent will prevent uretrovesical junction obstruction and fibrosis.
So what about leaving a stent? Will it sort of prevent immediate intravesical sort of installation? Will it cause any?
If at all, I think intravesical installation will cause a little bit of reflux, and intravesical agent will go upwards, get refluxed. But I'm not quite sure in practice whether there will be any harm. I don't know what Krishanti has to say about it, because
I don't think so, because it's just a superficial, the reaction. So I don't think it will cause major problems.
Yeah, I think I have seen some of the reports that people who put for the upper tract PCC also, they put intravesical sort of MMC gel, so as a preventive method. And the other question is, if you get from the expert panel, if you get a sort of a 50-year-old man, smoker with a 5 centimeter size, high-grade T1 disease, how would you approach, sir?
Anurudha should answer that.
From Anurudha, sir, yeah.
Yeah, he'll fall asleep otherwise.
He's a good candidate for radical cystectomy, but because intravesical BCG, the problem is, as Krishanti says, very poor acceptability, tolerance. And we actually tried about this giving radiotherapy with our oncologists. Few cases, Krishanti, and results are not that very impressive. It was a 50-50 thing, so not really impressive enough. For some reason, they didn't do well. So I don't know, if I can convince a patient, I think I will go for a radical cystectomy, because he's only 53 years. He has a 55 chance of having a progression of the disease in 5 years' time. So, and if BCG is also not doing well in our country, better to go for some form of radical treatment.
So do you consider any reconstruction with the
yes,
I agree,
yes.
sir.
Yes, yes, madam. Right.
Yeah, I agree, because even in muscle invasive bladder cancer, the response to radiation in Sri Lanka is disappointing. So I don't know whether it's an aggressive form. I'm not quite sure why it happened. So I'm not surprised that stage 1 patients did not respond to radiation.
Yeah, this popular belief, Krishanti, that if he's not suitable for radical cystectomy, he's not suitable for radical radiotherapy. Do you agree with it? So suppose due to advanced age, I don't want to do a cystectomy. So I resect it and send it to you, send him for chemoirradiation. Some people write back saying that he's not fit for radiation either.
No, I don't agree, but it depends on the performance status, because the surgical morbidity is different to the radiation morbidity, but sometimes administering chemo might be difficult. And the 6.5-week course is also a bit challenging in elderly. But now there was recent meta-analysis where the 55 grain 20 fractions is non-inferior to 64 in 32. So therefore, giving 4 weeks of radiation in elderly is, I have tried and they tolerate that better. It's a dose also a bit colder compared to the 6.5 weeks course, but they tolerate it better.
So if you are sending a 90-year-old patient with a bladder tumor, not fit for surgery, and if he's bleeding, will you give a radiotherapy to stop the bleeding?
Yeah, I will. 21 grain, 3 fractions, Monday, Wednesday, Friday. That's the best palliative approach, Valagobi, and 90 can tolerate that dose.
And from
Yeah,
Neville,
that's
sir,
given in.
yeah, if you get a bladder full of tumor, how to deal with it, sir?
Yeah. What I do is that I resect, do a partial resection to get a good sample from the muscle edge and the tumor. If there is more than 75% of surface has gone through field changes and there are multiple tumors, I don't bother to cut the rest. I will straight away go for a cystectomy rather than anything. But I have burnt my fingers by doing stage resections and then perforating and doing various things. If it is full of tumor, you get a good sample to find out the grade and the stage, and then you because their field changes have taken place in all of the place. So I would rather go for a cystectomy rather than following the usual guidelines.
Sir?
Some heroic, resectionist might get a good clearance and follow the guidelines. I have no objection.
Now, trainees.
I don't know what's Anuruddha's experience as.
Trainees, you can ask questions from experts.
May I ask a question? If it is a solitary T1 tumor in the diverticuli, which is unable to resect endoscopically, is it okay to straight away go for a partial cystectomy or the diverticulectomy?
What did you say, Anuruddha?
You can give a try and see, but I think there are few reports, again, mixed results, but we can give a try and see. I don't know.
Yeah, all depends on how nicely you can resect it, how deep you can resect it, and the grade of the tumor matters a lot. Because after resection, if it comes at G2 or G3 ASH grading, I think it's a dangerous tumor because there is no muscle to protect it from spreading. So I would rather go for partial cystectomies. Of course, on theory, it is always looked. It was not recommended, but I must confess that in older patients for diverticular tumors, I have done partial cystectomy, but that has to be definitely followed by chemoirradiation.
Thank you, sir.
Because that's a native bladder for an elderly patient.
I think that's a good option.
But during follow-up cystoscopy, if you see a tiny 5 millimeter, clinically looks like a TA, G1 growth, can we do a ablation with the laser fiber with the local anesthesia, sir? Or with the BBUP?
Yes, we have done it. Anuruddha,
Yeah,
that's okay.
definitely. Yes. Because we had in the unit where I worked, we had a separate laser list for all these tiny recurrences where you do it under local anesthetic, but you need to have to have a pre-wet connected so that you can use a sort of a 50 cc syringe to empty the bladder time to time. So you just fulgurate it and then empty the bladder, fulgurate it. And for the elderly people, I think that's a very effective way of dealing with the recurrences if they are tiny.
I have done that for upper tract tumors, very low-grade upper tract tumors with ureteroscope using laser in a single kidney, especially. I think that's a very versatile way to keep the tumor under control. The laser ablation.
I think Nalin have asked the question, Anuruddha sir, what about doing URBT under spinal with the obturator block?
Yeah, you can try that also. It's an option. Particularly with this COVID epidemic, it has been useful because anesthetists are reluctant to give GA. So we managed to do a lot of cases using that. If you have a good experienced anesthetist in giving local blocks, it's a good option.
And I think Umesh asked the question, about the survival benefit of mitomycin. Is there any survival benefit of mitomycin, Dr. Krishant?
There is mixed results, Balagovi, because some of the studies have said there is, but quite a few have said it's not, so it's controversial.
So it's only prevent the recurrence.
Recurrence and progression to muscle invasion. That's the main benefit from intravesical therapy.
Is there any prevention of progression by MMC?
That's right. You prevent progression to muscle invasive disease.
Any question from trainees to experts?
Just another question to Anuruddha sir. If you're going to do a TURBT, I mean, most of the time we will have to compromise and do it under spinal anesthetic. So, what are your advices if there's nobody to give a obturator block?
Learn to give it. Yeah, it's easy. It's easy because you can do a good trust-guided biopsy. When you're doing trust-guided biopsies, earlier in the private sector, we used to call the anesthetist. You do a good PR and feel the, you can, laterally you can feel the ischial spine. And if you can feel that, just lateral to the anal sphincter, the ischiorectal fossa and infiltrate 5 to 10 cc on either side, and you can block it. I think just watch one of these anesthetists do that. If anesthesia can do that, we can do it. So I think the best thing is for us to learn it. So biopsies, if the radiologist started doing it and urologist are doing it, so watch carefully or ask one of them to demonstrate it. Is that the question, Nishant?
Yeah.
Yeah. So I think we should learn. All urology trainees should learn how to give a obturator block.
Sir, any tricks of doing tumor in the dome of the bladder?
Yeah, it's a difficult area to resect, but basically it's, I mean, we all know, I think experienced resectionists, including you all, that you have to always maintain a half-filled bladder. And the bladder, when the bladder gets filled up, it moves away from you. So half-filled bladder and irrigation, the resectoscope with irrigation is very useful in that sense, because monopole resectoscope without irrigation or draining channel, the bladder keeps on filling up. And also keep to hold the resectoscope in one hand and press the suprapubic region down to bring the bladder to you is another technique, bimanual type of resection, holding it the resectoscope with right hand and pressing the tumor. And that way, most of the time, you can achieve a near total resection.
If you make a tiny hole in the dome, and if we recognize it early, can we manage with just a catheterization and no irrigation, or do we always have to open the abdomen?
Sorry, Balgop, the connection was interrupted.
Yeah, if you make a small hole in the dome of the bladder, any possibility of manage without opening the abdomen?
Yeah, what to do, is it?
Yeah.
I think it will be managed conservatively. What do you say, Anuruddha? I mean, I don't consider repairing it at all. But I think if you achieve good hemostasis, you can maintain very low flow, low pressure irrigation if you need it. But if it is very dry, even without irrigation, you can manage the bladder dome. And theoretically, I think you have made the bladder tumor into a T4 by going through the muscle wall. So I would rather send him to Krishanti for advice, because tumor cells would have gone out of the bladder confines. So that's a bit of a tricky situation.
Yeah, theoretically, sir, it is a possibility. And what the guidelines say is to perform a contrast cystogram on table. And if there is a intraperitoneal leak, you have to convert it and you have to repair it. But if there's no intraperitoneal leak, it may be a bit of fat layer covering, so that's adequate, so you can leave a catheter. And the answer, I remember when I was looking through the literature of a perforation of the, when you have happened, when it happens, intraoperative perforation, actually the literature is quite inconclusive about the upstaging of the bladder tumor. So there's no particular evidence to say that that causes worse prognosis or upstaging of the disease. So that is what the literature says. So, but I think we'll have to follow them up very carefully.
Yeah, I suppose I think you have to use your own discretion, because you can find the size of the perforation by comparing with the loop length. If it is about 1 loop length, it's a very small perforation. And if when you on bimanual palpation, there is no non-emptying masses or anything, no signs of extravasation, then of course you should manage conservatively. But if you see appendices, epiploic or appendix dropping into the bladder, some sort of a nasty situation like that, which I have seen appendices epiploic inside the bladder, and not my section, but that sort of situation, you are quite right. I think in that case, you don't have to do even a cystogram. You have to do open repair. It's like any other bladder injury.
Suppose we have perforated and there's a lot of bladder tumor inside the peritoneal cavity. Now we have washed thoroughly and we have repaired it. What about the follow-up management, Dr. Krishanti?
So then it's systemic disease anyway. The patient will need chemotherapy, Balagobi, because you have a, yeah. But bladder cancer and chemo, usually they don't do well.
Intraperitoneal MMC?
I don't think you can do MMC intraperitoneally.
The counter argument.
I don't want to lose my license.
The counter argument for the sort of upstaging is that when a tumor is superficial, it has not acquired the genetic potential to sort of reimplant or sort of have a metastasis. So that was the counter argument, but I think there's a lot of lack of data on all these rare issues.
But then the potential of tumor seedlings is the basis of intravesical chemotherapy. So these tumor cells have inherent potential of getting implanted. So peritoneum is a nice surface for them to get implanted. So those are all theoretical arguments, but in practice, I'm not quite sure whether we should do anything to the peritoneum.
True.
Balagobi, are there any more questions? Or I think we have had. So shall we wind up? Okay, and so on behalf of the Slough Academic Committee, I would be very grateful for all the expert panel, Dr. Krishanti, Professor Nilpera, and Dr. Amrita Begunasekar. Madam and dear sir, thank you very much for your fine contribution, and we had a wonderful discussion on this very exhausting topic, and many other things are not very clear because we send the patients in between the oncologist and the urologist. So It's a very good discussion for all the trainees and very educative. And thank you very much for your contribution. And all the trainees done a really good comprehensive presentation. And I would be very grateful if you could just stick to the time frame next time. So I know it's going to be a bit difficult because we are covering big chunks of urology topics in each uromed, but planning and restricting with the key component of your discussion would sort of give us a productive time to discuss the questions also. So thank you very much. And Baladev, if there's anything to add.
You're muted, but
Sorry, you are unmuted.
Next Uromed will be in a month time, so we will discuss the muscle invasive bladder cancer. So keep ready and read yourself, and we will update the progress. Thank you very much.